We also have Mr. David Harvey, who is the Executive Director of the National Coalition on STD Directors.
Good afternoon. Oh, that's better. Dr. Georges Benjamin, thanks so much for that overview of the NAPA study. I am very honored to be with you today. I'm sorry that I was not able to join you earlier in your process, but I very much benefited from watching the videos of the previous presentations, and so I have been playing catch-up on the status of your work. What I wanted to do today is to review a little bit of the work of what NCSD has been doing, some of which you already, I think, well know about, but more than anything else, really preserve some time for questions, answers, and discussions. You are talking to a creature of Washington, D.C. Most of my career has been spent working at the national level in the federal policy arena, and NCSD has been working very hard to try to change the equation of this issue and put it on the national radar, particularly through the appropriations process of Congress. And I was just talking to Gail in the back of the room because I was conveying new information that just came through about 5 minutes ago. What did I do? Is this the right control?
Yeah, you got it now.
Okay. And I see. Very good. And so one of the things I want to tell you a little bit about is what just literally happened in Congress about 10 minutes ago in terms of some good news around funding issues. So Congress is passing this year a $3.51 million increase to the STD prevention line at CDC. The significance of this news is not the amount of money, but the fact that we have pushed through a political logjam of bringing attention to this issue and this program and trying to make up for lost ground. Congress has not passed any increase in funding for this program in about 18 years, which is shocking to take stock of. What Congress also did was to provide all the money for the End HIV initiative that the administration had requested, which is $50 million for HRSA, PrEP, $70 million for the community health centers, $140 million for CDC under End HIV. The End HIV money is coming to CDC, a very important focus of the work of my organization to make sure that STDs are included in that initiative. And we have very high hopes for money being directly allocated for some priorities at CDC, in particular to support STD clinics in the context of ending HIV. Hepatitis got no increases, school health got no increases, infectious opioid, the funding line item at CDC got a $5 million increase. So this is all news that just happened, which I thought I would convey. So what I want to do is just review a little bit about the work that NCSD has done to commission the studies, much of which you have already heard about. In watching the videos of past presentations, one of the things I noticed in presentation after presentation is the lack of data, the paucity of data. And in particular, a lack of data about what's really happening at the state level about how funding streams are working. So I pulled out a study we presented a year ago in Dublin as one example of data that can point to some issues and trends within the field. I'm going to go quickly over that and then talk through what we hope for all of you as your work progresses. So I think you know a little bit about NCSD. We are the voice of the state, city, and U.S. territorial STD public health programs. We're the only organization of our kind in Washington. Unfortunately, there's not a lot of national STD organizations that have the resources or the capacity to engage in advocacy work, as well as national training in TA and other initiatives. We have placed a very big emphasis since I joined the organization 3 years ago to build up our membership base to include the partners of STD directors. So we have captured a large number of DIS in the United States. As members of the organization, we're working with them. And we've been doing a lot of work to try to support STD clinics in this country who are, I think, the long-forgotten safety net provider in this whole scheme. And so we have high hopes for the work there and the work that CDC is going to be doing. So, enough to tell you your charge. I am not commenting on many of these charges except around public policy and barriers in the healthcare system, which I'll touch upon. Dr. Benjamin just reviewed Phase 1 and Phase 2 of the NAPA study. 2 years ago, we decided at NCSD that we needed to generate some national attention and research and focus and taking stock of where we're at these out-of-control epidemics in the United States. So we went to NAPA. NAPA was very gracious in agreeing to do 2 phases of a study. This is the first study that you just heard a review of. I'm not going to go through all of these central recommendations, but I think we were thrilled to see, in particular, mention of a few things. The first is that stakeholders across the country, people who are leading these programs, know their communities very well. They know what the drivers are of these epidemics. We need to do more to listen to them and to give them the resources they need to be able to fight the epidemics in their communities. The other recommendations are all things that you've already heard a lot about: increased public education and awareness, expanding funding, a national STD champion, a federal STI action plan. That's very exciting to see come. And I think without a doubt, we must do more, different, think boldly around how to fight stigma around these issues. At our recent annual meeting, STD Engage, at our opening session, we did something we've never done in our 22-year history. We had a panel of 5 people who got up and actually admitted and talked about the fact that they had an STD. 2 were very famous HIV, or very well-known HIV activists for many years at the national level. And one of them in particular talked about getting her HIV infection after first having another STD. This kind of awareness, this kind of support, having people tell their stories is the way that we're going to change the minds of policymakers in how they allocate resources. And so one of the things that we're going to be trying to do is to support a better approach to raising the voices of people and their lived experience. The second thing that came out of these presentations, which, by the way, you can all see just like your own videos here, we have posted videos of our sessions at our website. But the second thing that really came crashing out of these presentations is that every one of them, unfortunately, had a horror story to tell about their experience with the healthcare system, their experience with clinicians who misdiagnosed them, mistreated, or used stigmatizing language. And inevitably, many of these people had to go and educate themselves about STDs and then, in turn, educate their provider. You have a real opportunity to turn this situation around in this country by commenting on that. We must do more to educate providers. Phase 2, similarly, got down more into the weeds, but we're thrilled with these recommendations. Creating program flexibility around funding streams. This has been an enormous area of our work over the last 3 years, in particular as you look at the silos between HIV and STDs. All too often, as you move into local communities across this country, you see HIV providers not testing for STDs, community health centers not testing for STDs. This is criminal in this day and age. Articulating a vision, you all articulating a vision for how to build a sexual health system in this country that uses the infrastructure built within the HIV world, we think is an essential recommendation that must be advanced. We are going to succeed at reducing HIV infections in this country. You know better than I that when that happens, there is enormous pressure placed by Congress and policymakers to take the money away. It is not too early for us to be thinking about a very bold vision for the future about how to expand, how to utilize, how to better even support the HIV infrastructure that's been built in this country with millions and millions of dollars and to put it to use for a broader sexual health framework. That is the only way, I think, we will hold on to these resources down the road and in the future. So, flexibility in funding streams, expanding access to care, again focusing in on safety net providers, focus on STD services, being much better at using data, and then of course supporting evidence-based education and awareness campaigns, particularly aimed at youth. This last recommendation does mention and focus on fighting abstinence-only programs. There's a lot of evidence to suggest, obviously, that those programs are not effective. We need comprehensive sex education programs in this country. That is a surprisingly complicated and controversial issue for some communities across the country. So I want to take you back to a set of data because, again, as I explained, this is a presentation that I presented in Dublin with my colleagues Jessica Fraser-Williams and Stephanie Arnold-Pang. And we did a national survey at the time because 6 months to 12 months prior, we actually faced a situation where in the president's budget, a proposed cut to STD funding, was proposed. We wanted to learn what would happen if that cut got enacted. This came right after, around the same time, that we had a reduction in funding through the congressional process, which we were able to thankfully reverse. We're not talking about large amounts of money here, but again, any amount of increase, any funding that we can hold on and protect in this field is an enormous success for us. So we surveyed programs across the country. We had a very good response rate. We heard from 40 or 50 states, 5 of the 6 directly funded cities. And what was interesting was to kind of see the trends about how these programs operate and how the money flows. So this slide shows the percent of total STD program budgets from different funding sources. And as you can see, an important source is other, including state and federal HIV dollars, some small amount of state and city dollars, and then the federal STD program. This is a system, a patchwork system that is put together with multiple different funding streams, and it is vulnerable to these variations in funding streams. This is another slide that shows that for every $1 of federal STD contribution, states and cities contribute about 43 cents on the dollar. That data is very uneven as you move across the country. This is the national trend, but it's very interesting to kind of take a look at this based on morbidity levels in these jurisdictions. DIS have been mentioned frequently throughout your work. Disease investigation specialists are the backbone of our sector. They play very important roles in HIV and other diseases. For the most part, DIS are very poorly paid. They have very limited training opportunities. We need to do much more to support this essential element of the public health workforce. But as you can see, our data shows 33% of the money that supports this workforce comes from the federal STD program, and then a smattering of other resources, including a major contribution from the HIV system. This is the number of DIS that we came up with in our survey. We think this is more or less accurate. We know that this workforce has been reduced because of funding cutbacks at the state and federal level, but this is what our data shows for the responses to our survey. STD Clinic Funding, we really wanted to start to learn about what was going on in this network of providers. STD Clinic, working with STD clinics has been a major focus of ours over the last couple of years. We wanted to gather current data on what's happening with these programs since there's a paucity of this information at the national level. You can see here in terms of 539, which were mostly standalone STD clinics. You can see how the money flows for supporting these programs. A lot of money to support these programs comes from state and city dollars. Federal dollars is very small. We're hoping to change that in our strategies working with Congress to create a federal funding streamline for STD clinics, which is one of the public policy priorities of NCSD. This data shows what would happen if there was a funding, a 17% cut to the program. Where would programs take it out of? DIS is the obvious first thing that people were looking at. So just a summary of this data shows that for every $1 of federal STD investment, states invest 43 cents. DIS are most at risk. 20 to 40% of DIS are funded with federal STD dollars. 64% of states and cities have state-funded STD clinics, which 539 clinics reported. These are just limitations of the study. We didn't get 100% response rate, but nevertheless, the data was pretty good. This study obviously shows the fragile nature of this system. And so as we move forward with recommendations coming out of NASEM and calling attention to the need in this public health system to support STDs, we hope we get less fragile. So in terms of what NCSD is hoping to see out of your work, none of this, again, is very surprising. But we hope that you call attention in a major way to the need for funding of this system, and not just from funding at the federal level. We know that states cut back massively on public health funding and STD-specific funding under the major recession, the big recession in 2008, and this system really has not recovered since then. The Federal STI Action Plan is a very welcome development under this administration, and we hope, we have high hopes for that plan, but we also hope that on a permanent basis, we have a federal interagency coordinating body. We know that any one agency of HHS cannot take this issue on alone. All of the agencies have a responsibility for dealing with this, from Ryan White to community health centers to maternal and child health block programs to CDC programs and others. Again, we've talked a lot about the flexibility in funding streams, and I know my colleagues and other presenters have commented on this. I think any recommendations that come out need to comment on this. There are unintended policy barriers by the way how some of these funds are flowing through legislation, but we think that there's some fairly easy fixes that might tool the system slightly better so that dollars can be used better at the local level. Provider education I've already commented on. It is an essential, really important priority that must go forward. And anti-stigma campaigns must be supported as we go forward as well. So my time is up. So we'll now move into questions and answers. Thank you.